All right, everyone, settle down, grab your notepads, and let's get entirely focused. I'm your host, but for today's explainer, I want you to think of me as your demanding maxillofacial professor. We're diving into a high-yield, intense masterclass on salivary gland disorders. This is designed specifically to prep you for the rigorous scenarios you're going to face, whether you're stepping into a busy clinic or sitting down for your board exams. We're pulling directly from premium source material to give you the exact diagnostic and management criteria you absolutely need to know. We're leaving no stone unturned today, literally and figuratively. Okay, let's take a quick look at the syllabus so you have a mental roadmap. We're covering 5 core areas. 1. Normal anatomy and physiology. 2. Infectious salivary gland disorders. 3. Benign and malignant tumors. 4. Autoimmune Sjogren syndrome. And finally, managing salivary gland obstructions.
Starting right off with Section 1, Normal Anatomy and Physiology, the baseline.
Listen carefully here, because you can't possibly hope to identify a pathology on an exam or, in an actual patient if you don't have a rock-solid grasp of the normal baseline. Pathology is, after all, just a deviation from normal. To really understand the sheer scope of this anatomical region, just look at this number, 600 to 1,000. That is the massive range of minor salivary glands distributed extensively throughout the mouth and the oropharynx. Any single one of these hundreds of tiny glands can be the site of an obstruction, an autoimmune reaction, or a neoplasm. But while those minor glands are supernumerous, the real heavy lifters are the 3 major pairs. We're talking about the parotid, the submandibular, and the sublingual glands. You need to commit these to memory right now. These are the exact, specific anatomical sites where the forthcoming major pathologies are going to strike. Knowing the location intimately, that's step 1 in your diagnostic reasoning.
Moving right along to Section 2, Infectious salivary gland disorders and their differentials.
Board examiners absolutely love to test this specific category, mostly because it requires you to rapidly distinguish between overlapping symptoms. So let me ask you this. A patient presents with a swollen, painful cheek. How do you distinguish between a bacterial crisis and a viral outbreak? Well, let's contrast these two presentations. Acute bacterial sialolithiasis can involve any gland, but it mostly hits the parotid. It's usually unilateral, presents with intense pain, swelling, systemic signs of infection, and the classic hallmark you can't miss, pus discharge. On the flip side, you have viral parotitis, commonly known as mumps. This typically occurs in children, is highly infectious with a history of exposure, and comes with prodromal symptoms like fever and malaise. But importantly, it presents as a painful preauricular swelling that is notably non-erythematous, meaning it completely lacks that angry redness you'd normally expect with a bacterial infection.
Now, because their etiologies are different, their treatments are radically different. For viral mumps, it's just symptomatic treatment. You just let the immune system do its job. But for acute bacterial sialolithiasis, you need a strict, board-tested intervention protocol. First, adequate hydration. Second, antibiotic therapy. And actually always try to get a culture of that pus first if you possibly can. Third, check for an underlying cause of obstruction, like a stone that allowed the bacteria to colonize in the first place. And fourth, incision and drainage, or I&D, if an abscess is formed. Do not mix these protocols up on exam day. All right, Section 3, Benign and Malignant Tumors, Identifying Neoplasms. Let's see how this builds our diagnostic reasoning. Shifting gears from infections to abnormal cellular growths, this brilliantly illustrates a classic presentation of a benign tumor, like a pleomorphic adenoma or a Warthin's tumor. Notice the clinical features here. This swelling occurs mainly in the parotid gland, it's totally painless, and it is slowly growing. When a patient sits in your chair and reports a lump they've just kind of ignored for a year because it doesn't hurt, this should immediately jump to the very top of your differential. But hey, we don't guess in medicine, right? We confirm. Here is your rigorous clinical checklist for these benign tumors. First up, diagnosis. You're going to order an MRI for a comprehensive imaging assessment, followed by fine needle aspiration to get an exact cellular diagnosis. Once you've confirmed it's benign, we move to management. It requires surgical excision. Depending on the exact presentation, this could mean a superficial parotidectomy, a lumpectomy, or an extracapsular dissection. Now flip the script and contrast that benign profile with a malignant tumor, something like a mucoepidermoid carcinoma. Here, the clinical presentation really shifts. You might see submucosal swelling, but the massive, glaring red flags are pain or ulceration. Benign tumors rarely cause ulceration. Malignancies absolutely do. And for treatment, while specific adjunct therapies are going to depend heavily on the tumor's grade, surgery is a non-negotiable step involved in absolutely all cases. Moving to Section 4, Autoimmune Sjogren Syndrome, Systemic Issues. Up to this point in the explainer, we've dealt with very localized problems.
A bacterial infection in one gland, a tumor in another. Now, we're shifting to a systemic syndrome that manifests locally. So the absolutely crucial point here is connecting systemic symptoms to highly specific diagnostics. Sjogren syndrome, or SICA, paints a very distinct clinical picture. Patients are going to complain of xerostomia, which is profound dry mouth, and keratoconjunctivitis, which is severe dry eyes. Demographically, this strikes females far more often than males. When you see this triad, the dry mouth, the dry eyes, and the demographic marker, you must confirm it. But how? Remember those 600 to 1,000 minor salivary glands we talked about right at the beginning? This is exactly where they come in. You diagnose Sjogren syndrome definitively via a minor gland biopsy.
And finally, Section 5, managing salivary gland obstructions through mechanical interventions.
This right here brings all of our anatomical knowledge perfectly back into play. Look, saliva needs to flow. When it can't, pathology ensues. When managing a stone without endoscopy, your strategy is dictated entirely by its location. Let's look at distal stones first, those situated right up close to the oral cavity at the very end of the duct. Because of their favorable superficial location, we use a very conservative, logical surgical flow. Step 1, milking the gland to encourage the natural passing of small stones. If that manual manipulation fails, we move smoothly to Step 2, a straightforward transoral surgical removal.
But what happens when that stone is proximal, like deep down, right up close to the body of the gland itself? Well, the conservative management we literally just discussed is no longer viable. Proximal stones represent a severe mechanical failure. They require authoritative, aggressive intervention. And by that, I mean complete gland excision. You take the whole gland out to solve the problem permanently.
Now, what's really interesting here is the tech. To avoid that radical excision whenever possible, we rely on advanced tools like siloendoscopy. Using a tiny endoscope, we visualize the ducts directly from the inside. If the stone is small, we execute direct retrieval through little baskets or microforceps. But if you encounter moderate or large stones, there's no way they'll fit through the normal ductal anatomy. In those cases, you absolutely must perform stone fragmentation first, followed by removal, or you utilize a combined surgical and endoscopic approach.
And you know, stones aren't the only mechanical roadblocks out there. Sometimes the duct itself is the actual problem. Other causes of obstruction include strictures, which is just a narrowing of the ductal walls. These conditions can only be managed through advanced endoscopy techniques, specifically utilizing dilatation to widen the stricture and stenting to keep the duct held open so normal, healthy physiologic flow can resume.
All right, we have covered a massive amount of ground today. We hit the normal anatomy, bacterial versus viral infections, benign and malignant tumors, autoimmune manifestations, and mechanical obstructions. So I want to leave you with a final, provocative exam question to synthesize everything we've just gone over. Based on the precise clinical presentation, how do you logically balance conservative, non-invasive methods against radical surgical interventions for salivary gland obstructions? I want you to really think about location. Think about etiology. If you can confidently answer that question, you are absolutely ready for the clinics and you are ready for the boards. Thank you for joining this explainer and keep studying hard.